Next up, we've got Nikki Stubbs, who's clinical team leader for tissue viability at St Mary's Hospital. Nikki.
Hello everyone, thank you very much for staying behind and last thing on a Friday afternoon, but we do appreciate it since we prepared the slides. It's good that we can talk to somebody. So I'd like to talk to you a little bit about an initiative that we developed in a large city in the north of England called Leeds, and it was a community and secondary care initiative where we developed a multifaceted approach to improving the prescribing of topical antiseptic dressings and systemic antibiotics for the management of soft tissue infection and related cellulitis. And I'm presenting today on behalf of the whole team. So in terms of what we did, I'm going to just run you quickly through the background, what the project strategy was, how we engaged with others in order to implement these changes, how we monitored and managed patient safety and satisfaction through this process, and then I'll just run you through some of the results, how we focused on quality and how we're kind of managing the efficiencies that we've realised and monitoring the outcomes on an ongoing basis. So in terms of the background, locally we were quite concerned about the escalating spend on topical silver dressings. These products have been very, very heavily marketed by industry, and there is a very, very small, poor evidence base for their use in the treatment and management of wound infection. So we'd realised this locally, and what's more, it had been recognised nationally. So it was very, in a document in 2009, there was national concern expressed about the topical antiseptic dressing spend, and particularly based on the poor evidence associated with their use. So locally we perceived that there was a need to improve patient safety in relation to wound care, to maximise and optimise the use of topical antiseptics, systemic antibiotics and wound sampling for the assessment and management of wound infection, and to address clinical uncertainty about the optimal management of wounds and soft tissue infection, given that the evidence base was very poor. So we needed a multidisciplinary approach, and this project involved microbiologists, tissue viability nurses, district nurses, podiatrists, pharmacists, you name it, we got them on board. And as with all of these projects that have been shown today, it was really important that we had a standardised approach that was as evidence-based as it could be, so that we could demonstrate that we were delivering safe, quality care. We wanted to have an inclusive guideline development process, so it was really clear what clinicians should do and how they should act in terms of assessing and managing wound infection. We revised the wound dressing formulary, and we developed a number of tools to enable us as specialists and clinicians out in the field to manage and assess wounds. And we utilised a citywide web-based resource so that people could access the guideline and the resources really easily. And as with any sort of pretty wide-scale change, we needed to ensure that we were educating people, bringing them up to a given level, disseminating what we'd done and what the results were that we'd realised, and as I alluded to, ensuring that patients were safe. So we drafted a guideline in our guideline development group, and that went out for consultation, and we did both sort of physical paper consultation as well as a web-based consultation process. We disseminated the guideline once it had been developed through things like GP educational events to district nurses, ward staff, pharmacists, podiatrists, as well as the clinical specialists in the field. We developed a decision-making tool so that we could actually direct people through a kind of process to judge whether or not patients were actually experiencing a wound infection and what actions to take if that was the case. Now you can see on the side of this slide, not expecting you to read it from there, but just to illustrate really that it was quite a complex, multifaceted kind of process to go through in order to establish a diagnosis, if you like. We had a hot phone number so that clinicians out in the field, particularly out in community, could ring a specialist and get advice if they've got concerns about wound infection in a patient. And this was particularly pertinent because what we did as part of the formulary review was we removed all the topical antiseptic dressings from the formulary, and clinicians could only access those products through the specialist tissue viability service. We set about a number of strategies for monitoring patient safety, and those included things like accident and emergency admissions, and we also monitored the referrals that we received from clinicians out in the field for patients who'd got suspected soft tissue infection. And throughout this process, we were monitoring patient satisfaction on an ongoing basis, and our excellent 100% didn't slip. So, in terms of patients and clinicians accessing our resources, you can see that we tried to ensure that no matter which way you went through the guideline group, either you went to an adult system, or you went to primary care, or you went to guidance, you could actually access this evidence-based guideline. So here are some of the results. You can see the white arrow at the top of the slide, and that's the time point at which the changes were implemented. And what you can see here is that, there's two things really. Firstly, that patients at the point of the implementation of the guideline were receiving penicillin as an IV therapy, which is no longer advocated for soft tissue infection in our local area. And so what we wanted to do was not only monitor that we weren't getting more admissions for patients with IV therapy for cellulitis, but also that we were achieving greater concordance with flucloxacillin prescribing, which was what we were recommending in the guideline. And as you can see, we achieved statistical significance for this. In addition to that, we were also wanting to ensure that GPs were prescribing the oral treatments of flucloxacillin as opposed to oral penicillin or multiple types of combinations of antibiotics. And as you can see from the purple bars in these charts, that gradually we've seen penicillin go down and the flucloxacillin purple bar increasing. Once again, you can see here there's two arrows. Firstly, when the wound guideline was published, and secondly, when the dressing formulary work was started. And what you can see here is a massive reduction in the number of topical treatments and topical dressings being used to manage patients' wounds. We were absolutely convinced when we started that clinicians were using silver as a just-in-case measure and not based on any clinical assessment of whether or not the patient had either a perceived very high risk of infection or whether they had an active soft tissue infection. So, and I think the fact that we haven't seen any increased admissions for patients, we haven't seen any increased use of IV antibiotics, has illustrated that actually removing topical silvers in a significant proportion of patients hasn't made a huge difference in terms of outcomes, but it's certainly made a massive difference in terms of savings. When we started this work, we were spending £500,000 a year on topical silver dressings within the Leeds Community Trust alone. We've now reduced that to £246,000, so we've still got some way to go, but certainly we've made a huge cost saving. So the next steps are that we continue to audit and feedback compliance with the dressing formulary and antimicrobial use, because as the previous speaker alluded to, unless you keep on them, they slip back into bad behaviour. We're going to simplify the algorithm because it is quite complicated at the moment, and we've learned as we've been using it that actually there are components of it which aren't quite so essential, so we need to make that more straightforward. We're developing robust mechanisms for capturing lower limb cellulitis in primary and secondary care, and we need to add to the body of evidence around the diagnosis and treatment of wound infection per se, because there's a significant dearth of that at the moment, and we're scoping the possibility of a research for patient benefit application to develop that robust evidence. So I'd like to acknowledge these people who were involved in this collaboration and this project, and I think it's over to Ashley, who's going to take questions. So thank you very much.